I'm a clinical pharmacologist, so I'm a little bit outsider, and I'm very happy to be invited nevertheless. And I chose a little bit a provocative title. Do you care about medication when you ask your patients how they feel? And the reason that I think it is important to care about medication comes with my experience in seeing patients, especially elderly patients, taking a lot of drugs at the same time. And when I ask them how do they feel, we very often get symptoms that probably you would submit under depressive symptoms. So let's take a look what polymedication and medication of many drugs can take part in our neurobiological behavior and health. Clinical pharmacology is dealing with drug effects or with the variability in drug effects in humans. So we are always looking at the outliers, persons who get side effects, persons who get non-response, therapeutic failure. And for this, we have about 4,000 different substances available. And for example, in Germany, and I think it's the same in the US, we have more than 100,000 drugs authorized. So we have a lot to do to figure out which of these drug effects may harm patients, for example. So what we are studying is vulnerability profiles for side effects, vulnerability profiles that we could use to predict and prevent side effects. And part of these patient vulnerability comes from our genes, our genetic makeup, and this is the field of pharmacogenetics, pharmacogenomics, looking at the genetic background for side effects. Can you understand me?
Yes, Julia, you are only on the first slide, and we see your screen, but not the slide following what you are saying.
Okay, perhaps I have to start it again.
Yes, please. Here we are on you. You must go full screen.
Can you see now?
Perfect. Yeah, perfect.
And if I move forward, let's see, can you see the next slide?
Yeah, perfect.
Yeah. Okay, so, okay, I hope it works now. Yeah, sorry, then you didn't see the...
No, we didn't see anything.
The important slide, yeah, what clinical pharmacology is dealing with. What you see now are patients with side effects. In the right corner, we have some pictures from a serious game that we compiled for medical students to recognize side effects. And you can guess what kind of side effects all these people have or may have. And that's what the students have to do. And the side effects can come from the many, many drugs that we have authorized. As I said, we have more than 100,000 drugs authorized on the market. And what we study is why patients are getting therapeutic failure or side effects and what predictive profiles we may dissect from the patients in order to avoid this dark side of drug therapy. Now, yeah. These are German data, but I think they are quite similar in the United States. We have an increase in drug prescriptions. And during the last 20 years, we have 60% increase in overall drug prescriptions. And if you look at the drugs that are taken, they are mostly off-patent drugs. So the old drugs, the generics that are taken where we have a huge increase in intake in our population. This may be the reason that we are older, growing older population, but it's also a way to treat diseases, to write out a medication prescription. This is also what is desired or expected by many patients. And now, yeah. We are part of a local population-based study here in the Rhineland. I'm talking to you from the River of Rhine country. And there we have a study, population-based study with 30,000 individuals. And we asked there for drug intake, and we learned that above the age of 65, so after retreat from work, 4 out of 5 people take drugs regularly, and every third takes more than 3 drugs. So we are here talking about polypharmacy. Polypharmacy is usually the word that you mention when an individual has to take more than 5 drugs on long-term drug therapy. So it's a very common condition in the normal, healthy population to take many drugs. And let's have a look what happens with polypharmacy. Of course, people have to take many drugs when they are ill, when they have multimorbid conditions, and often they are also frailty people.
Let's go.
And then the people get prescriptions, and the prescriptions should decrease the multimorbidity because they should heal this. So that's the upper side of the benefit risk ratio. But the downside is that taking a lot of drugs may cause a lot of drug interactions. And if you think about all these molecular ways that drugs are acting on, then you can imagine that there are a lot of possibilities that drug may interact with each other and cause other problems than the expected ones if they are taken alone. The drug interaction is one important issue occurring in polypharmacy. And the other one is that pharmacogenetics matters more. Pharmacogenetics is mostly on drug metabolism, and all of these drugs somehow have to be eliminated from our body. We have to get rid of these xenobiotic substances, and we use our enzymes in the liver, and there we have a huge variability in the world. By the way, we have the largest variability in African countries for pharmacogenetic variants in drug metabolism. And what happens in polypharmacy is that drug interactions get severe because all drugs that are metabolized by the same pathway, they will get stuck and they may cause side effects. So the problem of polypharmacy is we had a lot of reasons to get side effects. And side effects are symptoms of symptoms like disease symptoms. They are symptoms that bother the people and that contribute to multimorbidity, of course. So we increase the burden of disease when we are accepting these side effects. And on the other side, frail people with a frailty, people who risk to fall, for example, they have a high vulnerability to side effects, and side effects will get worse. So there's also in the other direction, the vulnerability arrow that increases the risk for side effects in multimorbid people. And on the other side, what we are doing against the side effects, we prescribe a new drug for headache, for example. We prescribe an analgesic drug, then painkiller. So we have these prescription cascades, especially in the old people, where we see, okay, then this drug was taken and then it caused a side effect and then the other drug was prescribed and so on. So we increase the burden of disease somehow. And how could we get rid of this situation that is a little bit a dystopia here, but it is a kind of reality. I will move to the next slide and show you the reality of our everyday life. We try to identify side effects in order to prevent. We try to optimize treatment in these people. And then we learn, okay, they are not taking the medication regularly. They have switched the medication, took the medication of the husband, or they drink a lot of alcohol with the medication, or they don't move, mobility is zero, they don't drink, and the renal function is also bad. So we have a lot of patient issues, patient individual profiles that contribute, of course, to the burden of side effects in polypharmacy. So here, a lot of practical work is needed together with science, and really with science to bring together data science and biological science in order to predict what happens in an individual patient. Now, after the introduction, I go to the antidepressants. Let's take this as an example. Antidepressant drug prescriptions. Here I found the data for Germany in the last 10 years. The antidepressant prescriptions rose. The neuroleptics and the tranquilizer did not rise so much, but the increase here is seen in the already high prescription rates for antidepressant drugs. And now we look at the burden of depression. We have, after the corona pandemic, we observed an increase in depressive symptoms reporting. And when we ask people for prevalence of depressive symptoms in the past 12 months, we have these rates in the age groups. We have in younger people about 10%, women higher than men reporting depression, treatment needed depression. But in the elderly people, we saw it's actually a decrease in prevalence, especially after the age of retirement. It goes down and it's about 5% prevalence of depression. And in the older people, it's slightly higher, but not as high as in the younger age groups, what you see here. And the women always a little bit above the men in reporting their symptoms. I don't know if it's really true, it's reporting symptoms. But if we look at the antidepressant drug prescription, then we face a different picture. And this is also what I always teach, that antidepressants you will find in elderly patients. The consumers of antidepressant drugs are elderly patients, but they do not have this high incidence of depression anymore, and the prevalences are low. So what is it about? You see here, we have about in the age groups above the age of 80, we have about 15% of the drug prescription, or prevalence of 15% of antidepressant drug prescriptions. So roughly speaking, elderly people above the age of 60 years have twice as high prevalence in antidepressant drug prescription than prevalence in depression. Many, that's what we also know, frailty. Many antidepressants are known to be potentially inadequate, especially in elderly people due to side effects, risk of special side effects. And of course, antidepressant drugs are metabolized. They have a lot of interactions and they are largely influenced by pharmacogenetics. There are even dose recommendations for antidepressants for pharmacogenetics. So they may be interesting in kind of polytherapy. I want to show you some pictures of my daily life. We have an outpatient clinic for polypharmacy at the University Hospital in Aachen. And we see patients above the age of 70 years. And we see them together with geriatric specialists. It's an interprofessional outpatient clinic with clinical pharmacologists and pharmacists who are really, really knowledgeable about all drug effects and drug interactions. So what we are doing is we look, or we ask the patients what they actually take. And this is already very interesting because it never coincides with the medication plan. So we ask them to bring all what they take, and we write this down in our database. And we ask them about mobility, because frailty is dependent on individual mobility. And we make a structured interview on symptoms that could be side effects. And we ask, or we teach the patients to do a causality assessment. So causality with the symptom. Was this a symptom that occurred unexpectedly? And could this be in the timely association of a drug intake? So in order to dissect side effect symptoms from disease symptoms, you have to perform a causality analysis, and this can be done together with the patients. And then we analyze the drug lists if they're potentially inadequate drugs, and we make a drug interaction check. There are programs, of course, available, and we look this, especially we do a safety check. What side effects would we not like to see in an elderly person? For example, fall risk increasing drugs are not a good idea in elderly people. And then we usually reduce the number of drugs. We try to reduce the prescription cascades, and instead of, for example, taking 4 painkillers, we try to reduce it. Sometimes we switch medication, and very often we also adjust the dosage. So that's the way we are trying to individualize polytherapy for the patient's need. And what we want to do with these data is to be able to do scientific analysis about adverse drug reactions and about patient-reported outcomes, safety outcomes, what the patient bother most. And we want to analyze drug-drug interactions and drug-gene interactions. We also ask the patients to provide a plasma and a full blood sample to do drug analytics and also to do pharmacogenetic testing. And this is all part of a European research project called Safe Polymed. So it's about safety in polymedication. And what we see is kind of this. We see that this is a cluster picture of a cluster analysis of the drugs an individual patients is taking. And we see that there are combinations that are typically taken together. We have several clusters identified in our patient cohort. It's now about 100 patients. So we hope to increase the cohort. But we already see some typical clusters. And here I show you the cluster of the drug classes, but the drug classes are not understandable per se. So I added the names of the drug groups. So we see what is very often taken together in combination are drugs for hypertension, atherosclerosis, metabolic syndrome, diabetes, but also neurodegenerative drugs and depression. Depression is here with the metabolic drug circle together. We also have another cluster, and this is typical for people who come to us after they already have a fall or a hip fracture, and then they are on multiple anti-painkiller, analgesic drugs, and sometimes antiemetics for opioids and antipsychotic drugs. So that's a different cluster, a different type of patient group we can identify from looking at the polypharmacy profiles. So in our patient cohort, about, I think, 102 patients now, we see 40% patients on antidepressants. So we have a selection. It's even much, much higher. And we are currently running a questionnaire where we ask the patients if they know why they are taking the antidepressant drug. Of course, there are other indications than depression, sleeping medication or pain. We want to ask them, and we want to ask them about side effects. Most of our patients do not know why they are taking the medication at all. They are in mean 82 years old, but they are taking the medication. And yeah, we have to follow up this issue. Why are so many polypharmacy patients on antidepressants? Now I show you the outcome of our structured interviews for side effects. And you see there are a lot of symptoms, patient-reported safety outcomes that are also connected to psychiatric disease or psychological, well, deterioration of health. Restlessness is very frequently reported, confusion in the elderly, fatigue over the whole day, sleep disturbances, of course, and listlessness is very frequently reported. And of course, you can say, well, this is not a side effect. It's a symptom of elderly people. It's normal. It's almost normal when you are old, but it's not normal. And when we do the causality assessment, we end up at least more than 50% of the raters, of the doctors, found that there is a causality association. It is at least possible that it's a side effect. It occurred during the time a new drug was taken, or the fifth painkiller was added to the medication, and then suddenly the mother did not go out of the bed anymore. So that's typically the causality that we try to assess here. So it may be at least modulated by the drug effects. And yeah, this is again the burden of symptoms and of disease that may be stressed by polypharmacy. And here, perhaps the antidepressant drug prescription is also, it may be provocative, but maybe a prescription cascade, because people are coming to their general medicine doctor and saying, well, I'm tired, I'm not motivated, I'm sad. And what they get is a prescription for an antidepressant. It's a very quick prescribed drug. And perhaps this may be one of the reasons that we face here a high rate of 40% of our patients with polypharmacy getting at least one antidepressant drug. But the dark side of the antidepressants comes also from another study that we are running. We are collecting, or we have collected, now the study is over, we have collected patient cases coming to the emergency departments because of side effects. And we have documented these cases. And here we analyzed the rate of psychotropic drug prescriptions and the side effects, why they were coming. And what you see is that fall comes out here, sticks out. Falls are really associated with psychotropic drug prescriptions. So this is what we for sure risk. Of course, it has been known. It's not us that we have not detected, but we have confirmed this in a case study of now 8,000 cases of adverse drug reactions. The falls are a very large subgroup of these adverse effects, and they are clearly associated with antidepressant drug use. The risk factors for falls are psychotropic drugs, elderly people, age is a predictive factor, female sex, fragility or frailty, and immobility. That's clearly associated as risk profiles, and we find it in our cohort of people who had to go to the emergency departments because of a severe side effect symptomatology. So perhaps we should do something to avoid these side effects and to improve the situation in polypharmacy. We know about vulnerability. This was the arrow going from the multimorbidity to the side effects. Vulnerability means that people get more severe side effects, or they get more side effects. One vulnerability profile is our genes. Pharmacogenetics, pharmacogenetic variants can lead to vulnerability for adverse drug reaction, either, and this is most frequent, because they are involved in drug metabolism, or because they are involved in genes that are leading to adverse anaphylactic drug reactions. So this is a very old study that we did when clinical studies were easy to do. In 2002, we gave different pharmacogenetic participants or volunteers, poor metabolizers up to ultra rapid metabolizers, the same dose of a drug that is affected by this polymorphism. And you see the differences in drug exposure. They are tremendous. And these tremendous differences can be translated to dose adjustments. So the poor metabolizer gets a smaller dose and the ultra rapid metabolizer gets a higher dose. These drugs are called actionable drugs, and we usually find information on pharmacogenetics in the drug labels already, and the FDA has relabeled a lot of drug labels, and also in the European setting now we have more than 70 drugs where that are actionable drugs, where really pharmacogenetic leads to a drug action. And the drug action is also outlined in guidelines where the dosing or the selection of the drug may be adjusted to the pharmacogenetic profile. So personalized drug therapy could help to avoid side effects. And one way to personalize would be to personalize according to our genes. By the way, this picture, I have the full copyright. We made a movie for another European project, and we were all, this is an actor, the patient was an actor, but all the other people were the participants of this project. So this is my colleague from Ljubljana, from Slovenia, and we did all together this consortium project about implementation of pharmacogenomics in Europe, in 7 European countries. We wanted to see what happens if we all use pharmacogenetics in the same way. And we all perform pharmacogenetics guided drug therapy in order to improve treatment. So the design was, now the study is over and it is published this February in the Lancet. We have included about 7,000 individuals, and it was a controlled randomized trial. One group got, or each study center was in a crossover, and one group got pharmacogenetic guided treatment and the other group was just standard treatment. And the interesting thing is that it was really overarching over disease fields. The outcome was the number of side effects, the severity or the burden of side effects. And it was performed in complete different disease context in psychiatry, but also in transplantation medicine, in oncology. And in Italy, we had the largest oncology hospital included patients. In general practice, in hospital pharmacy, internal medicine. So it was really divided up in all the branches where these drugs are taken, these actionable drugs, where pharmacogenetics matters. And what came out was that the rate of adverse drug reactions was 21% in the study group and 29% in the control group. So this means that with the personalizing drug therapy to the pharmacogenetic profile may lead to a large reduction in safety, in drug safety. Perhaps not in efficacy, this was not the outcome, but in drug safety, and 30% less side effects. In these patients that we see with polypharmacy, this is already something, because it's not taking one drug and perhaps having one side effect, they all have side effects. So this would be a way to reduce the burden of disease by reducing side effects. So coming to an end, the complaints of elderly people, they may be complaints of depression, of irritability, of anxious states, but they may also unravel the burden of adverse drug reactions. And I think we have a long path to go to learn what exactly we are doing when taking so many drugs together and administering these drug cocktails. By the way, we have data on what happens in drug interactions, but these data are only from 2 drug pairs. We have only empirical clinical data from 2 drugs. And even in our outpatient clinic, everybody takes a different combination. If you have 20 drugs, you do not find 2 patients taking the same 20 drugs. So it's really a field where I think data science is needed and analysis for drug effects in our body, where we know that they have a lot of effects, in order to personalize treatment and to understand, we can use the understanding of side effects for the prediction of a safer and personalized drug therapy. Yeah, and with this, I thank you for the for the invitation. I would like to give you some greetings of my group. This is my group in our labs, and this is the view to Aachen, to the city. But I have to say that it's the mountains are not really here. I miss the mountains. It's completely flat here, so there are no mountains. Yeah, and thank you for your attention.